Hi everyone. So first, before I start, thank you, Lina, for the speech. I'm still a bit emotional after the speech, and also I've been personally honored, really, and I feel privileged to be here today, to have listened to all the strong, powerful women who spoke to us today about access to basic rights, access to sexual rights, access to safe abortion, access to dignity and feminism, and I feel really inspired. And thank you all for this. Apart from that, we would like today to I would like to have my panelists next to me first, and yeah. So welcome everyone to today's session. We're moving, as Philip said, to a more technical conversation, but I think humanity and human beings will be in the heart of this conversation. We will be talking about a topic of immense importance, is the impact of structural inequity on access to medicines and treatment. As we navigate the complexities of global healthcare, it becomes increasingly clear that access to life-saving medicines is not just a matter of scientific advancement or pharmaceutical availability. Instead, it's deeply intertwined with the social, economic, political structures that govern our world today. During the inspiring conversations of this morning and this afternoon, our fantastic panelists explained how women and girls are at the receiving end of the systemic disparities and inequalities solely based on our gender. Unfortunately, this is not exception when it comes to access to medical treatment. Today's discussion will explore how these inequities manifest in various forms, from the pricing to the underfunding of healthcare systems in low-income countries. We'll examine the ethical, legal, and practical challenges that arise when life-saving medicines are inaccessible to those who need them most. So our distinguished panelists that I will introduce in a bit, who bring a wealth of expertise from the fields of medicine, public health, policy, and social justice, will share their insights on how we can address these inequities. They will also discuss potential strategies for creating a more equitable systems where access to essential medicines is a right and not a privilege. So I'll start with Dr. Morga. So Dr. Morga, she's a senior health advisor with 40 years of experience in health and medicine policy and programming in developing countries with international and national health development agencies and organizations, including the WHO, the Global Fund, Unitaid, Medicine Patent Pool, and the World Bank. She is currently senior policy and technical advisor to UNAIDS and the People Vaccine Alliance on access to medicines technologies. And she's a key advisor and also a member of different boards and groups around the globe. Then we also have the privilege to have Dr. Uni. Dr. Uni is a familiar face in MSF, as he has been previously the international president in 2010 to 2013. Dr. Uni has been a humanitarian worker and a public health professional for more than 2 decades, with extensive experience in the delivery of healthcare to populations affected by conflicts, disasters, epidemics, and neglect. He was the medical director as well, at some point in his career, of the MSF's Access campaign, and he had various fellowships at universities all around the world. Today, he is the interim director of the UN University Institute for Global Health. And last but not least, of course, Eldred Tellis. Eldred Tellis, he's, okay, oops, sorry. Yes. He's the founder and director of St. Calp Rehabilitation Trust, and is an activist for access to medicines. He has more than 40 years of experience in the social sector, working with street drug users. And as I said, he's the founder of the St. Calp Rehabilitation Trust. This organization has developed critical outreach services in Mumbai for harm reduction and basic healthcare. It was founded in 1995 and is a Red Ribbon Award winner in 2008 for leadership in the field of HIV prevention among injecting drug users. He has also received the Ashoka Fellowship for his pioneer work on harm reduction in Manipur, India, and also Eldred is a key activist for access to medicine for formulations related to HIV, hepatitis, and TB. So please, a round of applause for our excellent panelists today. Okay. So I have few questions for our panelists, and I will start with Dr. Morga. So, Dr. Morga, based on your experience and extensive work in the fight for access to medicines and treatment for women, what would you say are the major consequences of the structural inequity on access to medical treatment in an unequal health and research and development world?
Okay, first, thank you, very big thank you to MSF for inviting me here. I'm really honored to be here, and I just learned a lot from this morning and this afternoon. So just before we start about access to medicine, just a little statistic to remind ourselves that according to the World Bank, 100 million people fall into poverty every year because of health costs. 75% of that cost is medicine. And medicine includes medicine and diagnostics and things like that. And I just want to tell you that you know, when you're very young, something happens and it sticks in your memory and you never forget it. So I was a little kid. I lived in a poor area where I come from. Next door, a very poor family. But the lady just attracted my attention. I could see her now. Despite the poverty, she was always very well groomed. And her kids, I think she had 3 boys at the time, were very well groomed. They go to school and all that, and they were just looking from outside, looking really very well. And then one day, I heard my mother talking with the neighbor, and they saying, "المرض الوحش," the bad disease, which is the way we describe until now, the way we call cancer. And she had this lady, Hania, her name. I'll never forget her face. I'll never forget her name. She had breast cancer. So she went for treatment, I guess. I heard she had operation, whatever that was. You know, I didn't quite understand. But then after a while, she died. And just like this, the next thing I heard, she's gone. Gone where? Nobody told me. And then what I remembered after that walking the street, going to the shop to buy something, and seeing her kids in the street. Totally, utterly different picture. They were bare feet, they were dirty, they left school, the nice clothes that they were wearing kind of have gone, they were kind of dirty clothes, torn, and so basically they were, God knows what happened to them. They left the house after that, so I have no idea what happened to them. All that happened because their mother was ill, didn't get treated, and died. And this is not a story, well, it's a story from my past, but it's still happening. So if you look at what decides which research and development is going to happen, obviously scientists learn, scientists get interested in whatever they're interested in universities, and that is funded by the public, by your tax and my tax. Now, drug companies come in and see what will make profit in the market. And that's the medicine that they will take, or the research that they will take and develop into drugs or vaccines or whatever it is. At that time, my time, breast cancer wasn't really a big issue or a profit-making issue. So there was not that many research, that many drugs as we have now. Of course, now it's a big moneymaker. So now, women who have breast cancer cannot afford treatment. So like I have friends who have cancer who are from the US, from the UK. These are personal friends. And I have friends from other countries in the South who also have breast cancer. And the results or the path, the prognosis of both is totally, utterly different because of access to treatment. I actually have an American friend who was on death's bed, and we thought that she's gone. And the medicine was a magical medicine that brought her back. It was like the HIV story. The magic of HIV medicine brought her back to life. My friend, or rather my sister's friend at home, she couldn't have that medicine and she died. So you have the research and development. And once you have development, you have intellectual property rights. That's what companies do, and universities these days, they do. You put a patent and you control everything about that product that you're aiming to produce. Nobody can have access to the knowledge that you hold. So total monopoly. And then from that, you have a product at the end of the research development time. And then because you have a monopoly as a company, you dictate the price. So you dictate the price not according to how much you spend or how much it costed or whatever like logical calculation. You actually dictate the price according to how much the market can bear. And from that, you have the high unaffordable price. And I remember one time, of course, you hold, as a company, companies hold all the information about drug development secret because they call it the commercial information. They can't, you can't have access to it. So you can't have access to how much particular drug costed, except that the companies gave some information, God knows what, to a particular department that they fund in a particular university in the US. That department does some calculation and they come back every couple of years saying the cost of producing medicine is whatever. And I remember when I started work on access to medicine, roughly at the same time the Access campaign started, they said it costs $500 million to produce a drug to reach the market. A couple of years later, it was 700. Then it was 1 billion. Then then it increased until it was 2.3 billion. And I remember one day we were in a meeting with drug company, with the CEO of a particular company, and I was just sitting like that, and he was sitting in front of me. So I just looked at him and I said these numbers, and I said, so are you telling me that next year you would say it's 2.5, the year after or 2 years after would be 2.7, and it would just escalate? And he looked at me and I said, yeah. So I said to him, who can afford that price? And we're not talking even about developing countries. We're talking about the North. We're talking about Europe and America. Europe governments cannot afford that price, and the insurance companies in the US cannot afford this. The prices that result from what you say you spend on medicines. So what are you going to do? And he looked at me and he did that. So they just couldn't, it's like it seems, will make the maximum profit, and what happens, happens. People don't get access, we'll just give them a bit of charity. And what they say is that you have the market decides, and then when the market fails, because thanks to civil society, including the MSF Access campaign, we talked about neglected diseases for neglected populations, actually. So they kind of started over the years to accept, well, yeah, we're not doing a lot of research on malaria or sleeping sickness, we're not doing that. So because these research for that will result into products that are just they're not going to make profit. So we leave that. But that's a government responsibility. So they have the market, and the government carries what's left over. And they give charitable things to donations or whatever to other countries. When we start, I used to work in Oxfam. When we started the campaign for access to medicines, we went to meet various people, including the British government, the Department of Health. And I never forget, the guy, one of the 14 people that were around the table, he said to us, "You're going on intellectual property. This is the heart of companies. You won't get anywhere. They just wouldn't accept that. You better go for donation so they can give you some donation." And we talked about structural problems, that the system of innovation is built on profiteering, not on public health. So what's needed now to shift, to have a system of innovation and access that is based on public health for everybody, not for some people who can afford, but for everybody, those who can afford price and those who can't afford price. And to make that shift, it's taking a long time, but I think we're making progress. Again, big thanks to the Access campaign, MSF Access campaign. I can't thank every single person in the Access campaign enough for the hard work and the excellent work they have been doing, from HIV to TB, malaria, sleeping sickness, you name it, cancer, and now diabetes. You name any disease, you'll find MSF Access campaign has a big role in it. I'll stop here.
Thank you so much, Dr. Mohka, for navigating the structural barriers from a global perspective. You showed us how the pharmaceutical companies today dictate pricing and barriers that impact human life, that impact families and the future of children of these families. Thank you for that. We'll go now from the global perspective to the humanitarian perspective when it comes to access to medical treatment with Dr. Oni. So, Dr. Oni, so looking back at your career as a humanitarian, what have been the main obstacles in providing adequate treatment for vulnerable populations in humanitarian settings?
Thank you, Moga. So, I started my first mission, if you want to call it, or my first bit of work with Doctors Without Borders was in Ethiopia. In 1995, I was sent to the eastern part of Ethiopia, bordering Somalia, to provide tuberculosis care. And I remember at that time I was told, look, this is Africa. So, you have to make do with what we have. And we were allowed to treat only cases of pulmonary TB, but not those with non-pulmonary TB, because, well, that's what the system can handle. Few years later, I was in Uganda, and I encountered my first case of sleeping sickness. By the time I got to Uganda, doctors and nurses were unhappy. The treatment for sleeping sickness at that time was arsenic. It's an arsenic-based derivative. So injecting arsenic, we couldn't even use plastic syringes. We had to use glass syringes because the medicine corroded the plastic syringes. It was that toxic. But that's what we had, right? And the treatment itself killed 1 out of every 20 people that we administered the drug to. So that's what we had to deal with. And the situation, as Moga said, was there was absolutely no research and development being done because these were largely diseases that affected poor people in poor countries. I was also in Uganda when we heard that MSF was awarded the Nobel Peace Prize. So all of the discontent and the anger that was developing within doctors and nurses within the organization sort of manifested in a call for the Access campaign. That resulted in an Access campaign. Doctors and nurses were no longer willing to treat patients with outdated tools. Where they came from, in New Delhi and Boston and London, they had better treatments for patients. So why were those treatments not available for patients in countries where they work? So that's sort of the genesis of access work within MSF. But it wasn't easy. It was not that everybody was in MSF was on board with that. A lot of people felt that working on access, it was a long-term issue, development issue. It was not a work for emergency organization. It required long-term sustainable commitment to address those issues. So we were actually widening the scope of our work. But my argument has always been it was not the widening of the scope, we were deepening the scope. We talk about a humanitarian principle of respect and dignity, and if we want to be true to that principle, then we have to treat our patients with respect and dignity with the best possible tools that we are able to get. But that required us to work at different levels. So Moga just talked about some of the barriers we identified 20 years ago. One was innovation. And innovation does not always mean high-tech innovation. Innovation is also sometimes a change in the way you think about things, right? So we have the tools that work everywhere, all around the world, but it requires refrigeration. That itself it doesn't work in a lot of the places where we work, where we don't have 24-hour electricity. So we have to innovate, we have to bring tools that are field adapted. There are changes in the way we were delivering care. We didn't have enough people to deliver care. So what happened? Nurses started doing the work of doctors, community health workers started doing the work of nurses, and some patients started doing the work of community health workers. So task shifting. So these were all innovations that really sort of expanded our ability to reach patients in places where we were working. So innovation, right? Second is research and development. Like you said, there's no profit motive to develop drugs for diseases that affect poor people because they won't be able to pay. So one of the things that we pushed for very early on were countries to take responsibility to fund research and development for diseases that affect their own people. Why shouldn't India, with all of its scientific and technical resources, not fund research and development for diseases such as Kala Azar, for example, or Chagas disease in Brazil, right? So this became a big thing, and it led to the creation of Drugs for Neglected Diseases Initiative. So MSF, together with the Ministry of Health in Malaysia, the Indian Council for Medical Research, Institute Pasteur, the Kenya Medical Research Institute, and Fiocruz in Brazil, set up the Drugs for Neglected Diseases Initiative. And in about almost 21 years now, I think we've come up with 17 or 18, I think Kavita is somewhere here, but 17 and 18 new therapies at a fraction of the cost. Not 500 million, not the 2 billion that is often quoted, but at a fraction of the cost. So it is possible to do research and development for diseases that affect people, right? And the last thing is innovation. And innovation is supposed to be the heart of free market capitalism. But isn't it curious, at the heart of free market capitalism is a protectionist tendency. Intellectual property is not about spurring innovation. It is all about preserving monopolies, as you said, right? So we've never been, as an organization, we've never been against intellectual property. What we have been against always is profiteering, monopolistic practices of big pharma, right? So these were sort of the things that these were the political barriers we identified, and we thought we could work to address some of these. Now, in the last 20 years, I think there have been some remarkable successes, and maybe you will go into some of the work that we've done in India, for example. Remarkable successes. We've managed to put out many fires, but I think the forest continues to burn. Big Pharma has been really adept at co-opting access language and presenting schemes and presenting initiatives that look very good, but at the heart is all about creating new markets, right? Not really about access as such. So we put out a lot of fires, the forest still continues to burn. What has changed, at least for me, from where I stand in the last 20 years, is also access used to be a problem for poor people in poor country. That is no longer the case. You know, President Biden last week very proudly talked about how he's managed to sort of lean in on big pharma and drop the price of 10 essential drugs. That is because access is now a huge issue, even in the richest country in the world, right? So I think increasingly this is not a fight we can shy away from. And I think, I've been in MSF long enough to say that MSF needs to redouble its effort. It needs to stand strong. It needs to continue working on this, because if we don't work on access, it becomes very difficult for us to stand with people in all of the countries where we work and provide care with respect and with dignity. Thank you.
Thank you so much, Dr. Oni, for having shared with us your personal experience in MSF and having witnessed the genesis of access work in the field, then to the creation of Access Campaign, then DNDI. Thank you for sharing this. And also, your last point about that access to medicine is not anymore necessarily only a problem in the developing countries, but it's also an issue in the high-income countries as well. So thank you for sharing this. Now we would move to a different maybe perspective with Edred to talk from a engagement with civil society and community lenses. So what I would like to ask you, Edred, is based on your extensive experience working with communities and civil society organizations, can you elaborate on the main challenges and opportunities in the fight for access to treatment?
Yeah, thank you. So I'm part of community because I'm an ex-drug user. I quit drugs about 41 years ago. And ever since, I've been working for the welfare of drug users. And in 1999, when HIV was still something feared in India, one of my clients who had to drain an abscess in his tooth was rejected at a government hospital. Now here I had sent him with his HIV positive result, thinking that that should help him. So we weren't actually hiding the fact that he was positive. And in a government hospital in India, it's a teaching hospital. So you have about 30 seats in a big hall, and 30 students are attending to these people at one time. And so it's like a huge kind of a dental clinic. We're all in one hall. So I go there, and this guy was thrown out. And so I went back to the head of department, and I said, what's the problem? I mean, I've sent his positive result, so you all should take the required care and treat this patient of mine. She says, no, we won't. I said, how do you know the 30 people sitting in this room, none of them are HIV positive? Have they brought this test reports to you? She says, no, we've done our background questions. I said, show me what your background questions. Because here you have poor people sitting in that room, illiterate people, many of them women, who don't know anything about HIV, and you're asking them a question, have you ever taken blood transfusion? And have you ever had more than one sexual partner? And that's good enough to say they're not HIV positive. I said, what about their husbands having multiple partners? They, poor ladies, are just having sex with their husbands, but they don't know what their husbands are doing outside, and you haven't asked them that question. So how can you conclude that these are safe, and the person I'm sending you with a positive result is unsafe? So I kind of challenged that. And being a government hospital, I took them to court. So I had to actually oppose Government of India and NACO, which is the National National AIDS Control Organization, because they are the ones who see that there should be treatment for all. And we were fighting for a basic constitutional right, the right to health. So, to make a long story short, I won that case. I won that case in 2002. And based on winning that case, we got ART free for everyone in the country. It was the result of our case that ART was started. And post-exposure prophylaxis was compulsory in all government hospitals. So none of their staff could say that they are at risk, so they won't touch a patient. So PEP was there in all government hospitals, and ART was for free. That was the beginning. And this result, over the next 10 years, I used it to my advantage. I can briefly tell you all that too. But the main point is that I got a taste of this, rampant stigmatization, discrimination by government. And when the sentinel surveillance was done with injecting drug users, the first time it was done in 2003, it was done with diseases that could also affect the drug users. So they did TB and they did hepatitis C. And I was shocked. I was really shocked. In my clientele, in that sample, 58% positive for TB and 79% positive for hepatitis C. So I was really worried now, and I started taking more interest in hepatitis C. And at that time, in 2003, 2004, the only drug available was pegylated interferon. Now, this was an old drug, and it wasn't a very good drug in the sense that lots of side effects. It had some kind of 66% positive cure rates. And many people also let it go because headaches and all sorts of different problems. And yet that drug was costing 870,000 for one treatment, 870,000 Indian rupees. You can multiply the 3.5 times for Sri Lankan rupee. So that was something out of reach of the clients I was treating, because these are poor people on the streets. Now, what happened to make matters worse is people with HIV were mostly dying before of TB, some with pneumonia. But now we started getting, especially in Manipur, where I was working for Oxfam, people were dying from hepatitis C. HIV positive people were dying of hepatitis C. So I had to do something. MSF came to our aid, but MSF at 872,000, they're not going to treat 80% of my clients. So they've offered to treat, I think, 6 people to start with. And those 6, I had to choose now which 6. It became something that even now I had to discriminate. I had to make rules of which 6 would get the treatment. So, of course, we decided that those drug users who were non-relapsing, not going back to drugs, who were a little bit upward mobile, means keeping a job, looking after their families, we'll give them first preference. We had to make our own rules. But it wasn't a good feeling. So I decided I'm going to fight this battle with Roche. And that is when I took a post-grant opposition on pegylated interferon. It took about 5 years in court. And we went through ups and downs. At one point, when we were almost winning it, Roche challenged that how can Sankalp be an interested person? So the post-grant could be filed by interested persons. So Sankalp Rehabilitation Trust, my organization that filed it, they questioned how can Sankalp be an interested person. So we had to produce the results that 80% of our clients are positive. So we're definitely interested in the well-being of our clients. And the fact that there were people recovering who were taking the MSF treatment as well. So anyway, that was the last-ditch effort they tried, but we won the battle. The price came down overnight to less than 10% of what it was. Less than 10% worldwide. I never heard of Ukraine too much in those days, but I started getting emails from Ukraine, Belarus. I don't know where they got my email. And thank God for you, we are alive today. I was getting those kind of messages. It really was something I never expected. It was overwhelming, actually. But I realized that the fight that I fought, even my clients could not afford that 10%, by the way. It was still something near to 80,000 rupees. But it was helping people around the world. So we started taking up cases for hepatitis C drugs, TB drugs, HIV drugs. We fought a lot of cases. Touch wood, we won most of our cases. The point was that then came sofosbuvir, the magic drug for hepatitis C. Sofosbuvir, 84,000 US dollars a course for 3 months. 84,000 US dollars? And our Institute of Biliary Science in Delhi is actually became like what we call a broker or a dalal, for lack of a better word, of helping people to import the drug at 62, 64 lakhs of rupees. When there were many chances on compassionate grounds, some people could get it even free. But they were not bothered to fight a fight. In fact, when I took an opposition at the Institute of Biliary Sciences, they brought the cops to put me in. Luckily, there were some people from WHO, and they said, but this person, he's doing a silent protest. He's not shouting, he's not damaging, he's not being violent. You can't put them in. WHO saved the day for us. But, but the fact was that this big institute was not using its clout to help. They were trying to get money towards these big pharma companies. Gilead was the company they were getting it from. So we fought this battle against Gilead. Gilead people came to Mumbai, 7 vice presidents, and they invited me to a 7-star hotel in Bombay for a meeting. I said, no way, I'm not coming to a 7-star hotel because the expenses of that hotel are going to go on the drug to my clients. I don't want to be part of that I would even have a cup of tea, which would be charged to my clients for the drug. If you want to meet me, you come to my office. They said, we are 7 of us, do you have a place? I said, yes, I have a place, and I'll give you chai as well. They came to my office. Believe me, they had done a lot of background checks on me, on my personal life. So they tell me in between, okay, they came with good news. Just for your sake, we have got an India price of 2,000 US dollar entry price on sofosbuvir. So I know it's 84,000 the US. They're making a 2,000 entry price for India. I said, I know what it costs. Sofosbuvir was bought over, the entire organization you bought over for $11 million with all the assets and everything. And sofosbuvir was one drug. And you've already made 25 billion profit in the first year. So where's the pricing of $2,000 coming from? I said, anything above 500, I'm not stopping myself. I'm going to sue you on this patent. So they invited me to the launch. Okay, we're going to get it down. At the launch, they launched it at 900 US dollar in India. And I said, are you joking? I said, nothing above 500. And I walked out. I said, you're wasting my time. I went to court and brought the price down to 100 US dollar. So, and believe me, it's still being sold at 84,000 US dollars out there in the US. So it's absolutely crazy. It's scandalous. The amount of money they're making is scandalous. Furthermore, since it came down to under 100 US dollar, I convinced our government that we've got so many people who need it, and it has to be given free. So it's made free in India to 20 million people who need it. All people with hepatitis C can get it free in India. That's how we had to fight this battle. And this has really encouraged me, to make a long story short, I know I'm taking more time than I'm supposed to, but to make a long story short, we took on more such battles. Gleevec was a drug for cancer. It actually had nothing to do with my clients. But the main point was Gleevec, Novartis was actually challenging the basis of our law, Section 3D. Section 3D is a beautiful section that we have in India, which says incremental changes in the nature of the drug without change in efficacy cannot be repatented. And Gleevec was finishing its 20-year patent. The drug was being sold for 121 rupees per month to anyone who wanted it. 1,21,000 per month. It was completing its patent term. They were making it from powder to a crystal form. Nothing else changed. So we challenged that. The Cancer Society challenged that. I gave them a lot of support. In fact, this film you showed, I think it shows me also there with Gleevec, the Gleevec fight, where we brought the price down. The Gleevec victory brought the price down to 4,000 rupees, Indian rupees, from 121 per month to 4,000 per month. So companies could give it free to their employees. Companies were now giving it free to their employees. Earlier, the people had to pay for it. So 1,21,000 to 4,000. So a big change, but we fought that fight because we did not want 3D to be out. So section 3D remains, which says incremental change in the nature of the drug without change in efficacy cannot be repatented. And most of our oppositions, we use 3D. The innovation, of course, is used. Many drugs are repurposed drugs. Remdesivir for COVID, repurposed drugs. Pegylated interferon was also a repurposed drug. These are drugs which no new research has been done, but the prices, they're getting the patents and the prices are beyond the reach of the common man. Why common man? Beyond the reach of most people. So this encouraged us to fight. Today, I have challenges running in court presently, 26 cases for patent challenges. But the government is trying to stop me now. The government is trying all its efforts to stop us from challenging these patents. So there's a new law that's coming up now, which does not allow, first of all, pre-grant oppositions are going to be very difficult because we cannot do research. They have shortened the time. And they're also saying that if the company pays X amount, 50 lakh, for registering the patent, if I want to oppose, I should pay 50 lakh. Equal amount. The company is doing business. I'm not doing any business. So if I want to now challenge it, that's the new law. But I've decided I'm going to challenge this new law as well. It's just not on. So anyway, to make a long story short, I'll end here because I've taken more time than I should. But if there are questions, I would be glad to answer. Thank you.
Thank you so much, Elder. Thank you for sharing with us your fabulous personal story in fighting first for the marginalized populations, such as injectable drug users, to access to hepatitis C, HIV, TB treatment for better affordable prices. Also, I've witnessed personally I've been following the Gilead case very closely. It's a case that is very close to my heart, and I didn't know that you were this heavily involved in that case. So I'm very honored to be with you in the same panel today. And I think you showed us today, and you are a real life example of showing us how the power of people and civil society in shifting policies and practices when it comes to access, and we can even apply it to other areas in this world, is really crucial and important. So thank you for being here with us today. Thank you. So before moving to the questions, I would like to, you've talked, the three of you have been in the field of access to medicines and treatment for decades now. So you have been saying that things have been evolving in a positive way sometimes, maybe less in other cases. How do you see the future moving forward? How do you see it now that Eldred, for example, talked about these new laws in India? How do you see the future, globally speaking, and maybe bring it to the region, if possible, to women? So we have some time, so we can. I'll let the three of you actually discuss this and take it to other direction if you want as well. You're free.
Okay, so just to say that one of the positive things that happened is that, until very recently, I would say, research and development. So research used to be, and clinical trials used to be mainly on men. So there is no clear research on women, as if something works on men in such a way, it will work on women in the same way, which we know is not true. And just to add to that bucket, that there was also most of the clinical trials on white Caucasian men. So brown, black men are kind of not part of the story, let alone brown, black women. Of course, they're out anyway. So that has been changing, and the one particular research that I've been following is COVID. So the clinical trials on COVID covered men and women of different ages and different colors and different sexuality and HIV status, and lots of the diversity of humanity was included, including women. And that for me was like gender equity is moving a little bit into access to medicine. In terms of intellectual property and the effect it has on price and therefore on access, again, things have moved. So in 2001, so a year or two after the Access campaign, there was a huge global civil society campaigning, especially on HIV medicines, because at that time, the medicine were in the north and the majority of people who needed it were in the south. To the extent that in 2001, if you remember, the UN held the first General Assembly meeting on a disease, that what we call UNGAS, the UN General Assembly special session on HIV. And I walk into the UN building, and there was a sign top to down, like a huge sign, even bigger than this one because they have higher walls. And it has a picture of an African woman on bed, so obviously looking emaciated and really ill, and another woman sitting next to her holding her hand. And underneath it says, "You mustn't die alone. So you mustn't die alone." And I really wanted to scream, because she mustn't die full stop, because there was medicine to stop her dying. But of course, even at a UN level, we were not talking, or they were not talking about access to medicine. And it was thanks to civil society and communities and people living with HIV that that situation changed. And thanks to India, the pharmacy of the world, where they produced the antiretroviral medicines. This is stories that should be taught everywhere, and it shouldn't be forgotten. The price of antiretrovirals came down from $10,000. At the time, it was a lot, $10,000 per person per year. It came to $1 a day. At the time, now it's less than that. $1 a day, thanks to Dr. Hamid and thanks to Cipla from India. So, and that is a result of huge civil society campaign globally, north, south, east, west, you name it. So once that came down, of course, and at that time, I have to tell you this story. I think he was the head of USAID, somebody important in the US anyway. He went to Africa. He came back to say, well, how can you give Africa the medicine? They don't have watches to know the time. So thanks to Cipla, the Indian company, they put the three medicine, at the time they were these three medicine, they put them in one pill, and the idea is you take one pill at sunrise and one pill at sunset, and you don't need a watch. And I mean, you know, Cipla should have had the Nobel Prize for that. Anyway, so that really tracked, you know, a snowball of activity around HIV. We're campaigning against Gilead now on lenacapavir, which is a new medicine that you just have it twice a year, and that's pre-exposure prevention drug. So can you imagine the effect on that on women? So women, instead of having pill and people looking and stigmatizing them, they can take that treatment every 6 months, and they don't have to have, you know, people knowing that they have to go to the clinic and get a medicine every month or every week or every whatever they take it. So that's, we're still fighting for pushing Gilead to make it at an affordable price, or to share the technology with companies like in India that can produce it at fraction of the cost. So these are things are happening, are changing. Just after the Access campaign, 2 years after the Access campaign, with all the campaign that everybody was involved in, the EU Commission, they decided to hold a meeting because we were all against what the World Trade Organization is, the laws or the rules that the WTO was making, including the one on intellectual property, but there was other rules on agriculture and other things. So what the Europeans decided was to hold a meeting once every month. And they said to us, you select yourselves, we're not paying for anybody. So we used to go, and what they used to do is one side of the table is pharmaceutical company, one side is NGOs, or civil society, and one side is the European Commission, who love to say they are the honest broker. And then that side is like the screen where you can put presentations. And drug companies at the time utterly refused to accept that price is an issue, for price even as an issue. They kept saying it's poverty. So we kept saying, so what? So we wait until poverty is eradicated. Meantime, how many millions will die from lack of medicine? Then they, well, yeah, but it's not intellectual property. So that was 2001, roughly. 2010, there was 10 years after the intellectual property rule, and I ran a panel like that, and I insisted on getting the pharma guy who we used to fight with. I got him on the panel to talk about it, and he said, yes, intellectual property is an issue. 10 years or 9 years of fighting to make them understand that intellectual property is a problem. And now they've become so clever. As you said, they're using the access language that we have. They talk about innovation and access. They used to talk about innovation, that without monopoly, there's no investment. So you would have no medicine. Now they talk about innovation and access, but access a la their way of we will provide it. So like, during COVID, for example, where the research was funded by the public, by our tax, and yet they make the money. So we have three things happen during COVID. Scientists invented vaccines. Pharmaceutical companies made gigantic profit that they never made in their entire life. People in Africa and other developing countries did not benefit from the vaccine, or they benefited very, very, very late when COVID was not a particular issue. Yet they claim that they're the inventors of the vaccine, that without intellectual property, there will be no vaccine, which is absolute rubbish. It was without the investment of the public in research. And the other thing is, because I was watching what would happen, I really monitored it day by day. From the day China said there's a disease affecting the lungs of unknown origin or something like that. They didn't even have a name for it. So I was following it every day thinking, would we have a medicine first or a vaccine first? And I think companies came into development for two things. One, they were sure of the market in the sense that they will need to vaccinate the whole world, and that the disease will come again and again, like it would be like seasonal flu, where you have a vaccine every year. So there is an assured market, and governments poured money, literally poured money on research. Then they started developing, Pfizer and these guys started to develop the vaccine. And the head of Pfizer, sat in a meeting, kind of very proudly says, when I go to restaurants, as I walk in, people stand in, what do you call it, ovation for Pfizer. I mean, even the development of the vaccine, it wasn't Pfizer. Pfizer manufactured because they have the capacity to manufacture. It was the other German company that actually developed the vaccine. And the whole research was done in American university by American taxpayer money. Anyway, so he said, and all we need is governments to pay. If they pay us, we will produce enough doses for the world. So one company is the almighty company that will produce vaccine for the whole world. This is at the time of COVID when they said, and Bill Gates said, well, maybe we don't have to have the same vaccine for everybody. So they wanted AstraZeneca vaccine, which is Oxford University really. They wanted that vaccine for people in the South because it doesn't require particular refrigeration, and keep the Pfizer Moderna vaccine for people in the North. And we had a fight with COVAX to say, why don't we have that vaccine available for Africa? And Sis Berkeley, the head of Gavi, said, well, instead of paying money for refrigeration now, and then we wouldn't need to use it afterwards, we will wait and use the AstraZeneca vaccine. And using the AstraZeneca vaccine for the simple reason that Oxford University put conditions on AstraZeneca that they were not going to deliver the formula for the vaccine, the knowledge for it, without two conditions. One, it goes non-profit price, and they looked at the books to see that it is non-profit, and it prioritized people in developing countries. And AstraZeneca had to agree on that. And therefore, the AstraZeneca vaccine was available. AstraZeneca is not a vaccine-producing company, so they couldn't produce it. So they went to Serum in India to produce for developing countries. And when India was at the highest crisis of when we see in TV people dying in the streets, so India stopped export. So people in Nigeria didn't know when they will get the second dose, and their relatives didn't know when they get the first dose. And everybody said, oh, India stopped, India stopped. Well, it's not, and they wouldn't admit that the problem is not India stopped, and India did, India should have left their people dying and export the vaccine. I mean, where is the brain? Where is the logic there? The problem was not sharing the technology with many other producers that can produce, and therefore you have enough supply in developing countries. We're fighting this, you talk about change, we're fighting this at the current negotiation of a pandemic treaty or pandemic agreement at the WHO, where we're saying if WHO says there is a pandemic or there is a danger of a pandemic, then we have to have certain measures. In fact, we have to have these measures to prepare for pandemics. So these measures include sharing technology. Number one, sharing technology and know-how. Number two, waiving or removing or whatever you want to call it, intellectual property barriers. And then our countries and donors, but our countries in the South must prioritize health, prioritize medical research, and invest in local production. We don't have to wait until a donor brings some doses that they don't want, or we don't expect donors to come and fund our, fund our factories to produce. That's just not in their interest. What's in their interest is if you, as a government, start your local production, start investing, showing the political will, then you can ask them to come with money and technology and other things. So, but what we're fighting is the technology transfer. This is really a big sticking point because, of course, the northern countries, with support or looking, taking the position of their pharmaceutical companies, don't want shared technology. And that is what's happening with monkeypox. We walked through COVID with huge inequality in access to vaccines to the extent that President Ramaphosa of South Africa called it is vaccine apartheid. This is a big thing from the president of the country that had that political system. So did we learn from COVID? Absolutely not. We're fighting the fight in the pandemic agreement. And here's monkeypox. What's happening with monkeypox? Monkeypox was discovered in 1970 with a 9-month-old baby in DRC. Did anybody, and the researchers from Africa were screaming for funding for research. Nobody funded them, North or South or anybody. So now when monkeypox in 2022 was announced as a pandemic because it hit Africa, it hit Europe and America, then, research. We did, and the Americans discovered that the vaccines they were funding for smallpox because they were worried about bioterrorism after bin Laden business, it can work for monkeypox. So they started stockpiling. Then WHO in 23 said, well, it's not a pandemic anymore. They ended the pandemic status. Fine. Does that mean that monkeypox ended in everywhere in the world? No. It stayed in DRC. And it started actually later 23 and now 24, it started increasing. Did DRC get 1 dose of the monkeypox vaccine? No. Now, after kind of a lot of pressure and I guess worrying about people screaming about technology transfer again, the US said they will give, I don't know, I think 50,000 or 60,000 doses. The EU is buying doses for Africa. The company that produces that, it's a small company in Denmark, decided to give some doses for free, or I don't know, donate, whatever donate means. But none of them has reached the DRC yet, but at least there is some of that. And that is the model that they are promoting. We will give you some doses when we feel like it, rather than we will allow and enable your companies that can produce, by sharing our technology with them, they can produce and have a sustainable supply for your people. That's kind of not on. What is on is we'll do it our way. So I think we have a big fight there. That's why we need the Access campaign. Please, MSF, we need the Access campaign to campaign with us that we have technology transfer and removing IP barriers as key things, key elements of the pandemic agreement.
Thank you so much, Morgan, for sharing with us extensively the intellectual property issues in the past, today, and possibly in the future. And also you provided some recommendations. What I can say quickly on your last comment about the Access campaign, what I can say, I think, confidently, is that MSF will continue the work on Access. That's a commitment, clear commitment from MSF, and will continue working along with other humanitarian actors, international health organizations, and civil society to improve access to essential treatment. I'm looking at the time, so we're open to the questions. So please, if you have any question, raise your hand. When you take the mic, say your name, your position, and if you have a particular question to specific panelists, also you can say the name of the panelist and be concise, please.
I'm Dr. Prithviraj, Humedica Lanka. Just want to ask, can I sit and talk? What ethical framework should guide our approach? Kind of, because I hear you talking about like 6 patients, right? Out of that you came up with the criteria and things like that. That's fine. But we are talking about collaboration. Can there be any kind of a regional collaboration to understand what type of ethical framework should guide our approach to ensuring access to medicine as a fundamental right? Or how do we balance individual rights with the public health needs here in a resource-limited settings, as well as the VUCA context, that is volatility, uncertainty, complexity, and ambiguity. With that, we can add mistrust. There is a total trust deficit globally in that sense of people don't trust each other. So how do we, is there any kind of guidelines, or can you talk about it? Ethical framework, yeah.
I'm not sure if I can answer this question, tell you the truth. The example I gave of 6 patients was what was offered to us. So I know it's not very ethical, but the best we could do is to save those 6 lives because that was offered to us. In terms of generally when we have problems and we have like you can say like an epidemic coming up. Now TB, India is the is the capital of the world. And sadly, MDR-TB, Mumbai is the capital of India. So we had this problem actually with when she was talking about gift. Johnson & Johnson gifted a certain number of doses to the Indian government of bedaquiline. Now, bedaquiline is a drug used for MDR, TB. The Indian government had some weird idea that they decided to split that to the 5 metros. 5 metros of the country will get 1/5 of those, the gift. Crazy. Just Delhi, Bombay, Calcutta, Madras, Bangalore, whatever. So those metros had some 2,000 doses each. They decided only to give it to people who lived in that city. Crazy again. There's no ethics in it. I'm giving you the story because there was one young girl, Shriya, 17-year-old girl with MDR-TB. She needed the drug. She was living in Dehradun. And from Dehradun, her very poor girl, her father brought her to Delhi because he heard that in Delhi there's a certain quota. They didn't give it to her, the government. They said, prove your domicile of Delhi. And this girl, I think MSF also helped her in the case. I'm not sure about it. But this case went on for more than a year. She had to prove her case, 17-year-old girl. And when she won the case, her health deteriorated so badly that when they gave her bedaquiline, it was too late. She died within a month of winning the case. She won the case and died within a month. So, I mean, this just highlighting that there's no way that, these things can be done in terms of quotas and all that. Absolutely. Now, I know it's not the answer to your question, but what we are forcing the government to do is when there is a need, there should be a compulsory license issued. Now, why is Gilead's drug become so cheap in India? They gave 5 companies a voluntary license. The voluntary license were given to X, Y, and Z, Mylan. I don't know which are the companies exactly. But that's why the drug is so cheap in India, and it still has 84,000 US dollars in the US. So we have to force the government to do a compulsory license for such drugs. Bedaquiline is one. I mean, I think Mumbai has almost 10,000 MDR-TB cases alone in Mumbai. It's a capital. So there is a need, and under the circumstances, we have to convince the government for a compulsory license, because there is no ethics in how you distribute a limited amount of drugs, really. This was crazy that they decided geographically to give 5 metros, and then after giving 5 metros, not even giving the person in need. So I can't answer your question really, but what we are doing is trying where there is a need, large need, and the drug is too expensive. Bedaquiline is out of reach of the common person. Compulsory license is the need of the hour. Maybe Unni, you can say something.
There are papers you can read. Emmanuel and Manuel have written a really interesting paper on different moral and ethical frameworks you can use to make decisions in resource-constrained contexts. So maybe, and that's a good, there are many frames you can use to make these decisions. But, it's still very painful for the person who has to make it. Because, ideally we shouldn't be in that situation at all. I just wanted to raise 2 very quick points. So we talked about innovation, we talked about R&D, we talked about in-access issues. But one new element that we increasingly recognize, also heightened by COVID, etc., is the impact of trade policies on health. And there's a lot I can say about that, but I'll give you one anecdote. I was talking to an Indian official when the negotiations were going on with Europe about free trade agreement. The thing about Big Pharma is that they get governments to come and bat for them. So it's governments putting pressure, Europe and US putting pressure on countries like India on behalf of Big Pharma. So I was talking to them about, but how can you make these decisions? I mean, look at the health needs in the country. They said, no, but the negotiations are, if you give up 3D, we will push for a seat for India in the Security Council. So these are the kind of discussions that are happening at that level. It's nothing to do about the health of people, right? So that's one. Trade policies have huge negative impact on the health of people. Second is governance capture. We now live in a world where global health decision making, agenda setting, priority setting have been captured by philanthropies and powerful countries. So people like us living in countries we live have very little say in some of these matters. And when they make these decisions, they preserve the power structures. So they're very unwilling to give up on IP and other profit generating sort of policies that they have. So these two things I just wanted to quickly raise.
Thank you very much. Thank you so much. So thank you for our panelists for having shared with us the challenges, opportunities, and some recommendations when it comes to access from global health perspective, from the humanitarian perspective, and from the civil society work perspective. So thank you very much. And one last thank you to a person who is not here with us today, is to Lina Mangani, who is the intellectual property advisor for MSF, and she's the head of the Access Campaign India, who has been working in the background to build up this panel and to bring our valuable panelists today. Thank you very much.